with the identification of the follicular dominance. In a normal length cycle, it is around by the 5th day that the dominance of the follicle is selected, and it becomes evident on ultrasound almost instantaneously. But it is to be remembered that the dominance of the follicle is not just the size. It is the sensitivity of the follicle to FSH, and that is denominated by not just the size of the follicle, but the blood flow surrounding the follicle, which starts appearing soon after the dominance of the follicle is selected, as seen for this follicle. As the follicle, after achieving dominance, grows, since it is dominant and it is sensitive to FSH, the normal growth rate of this follicle should be about 2 to 3 millimeters a day, though there is some literature which also mentions 1 to 4 millimeter as the limit. Ovulation usually occurs when the follicular size is about 18 to 24 millimeters. If this follicle is to be followed, the first scan, of course, therefore, must be done on the first dose of gonadotropin, just before starting gonadotropin. If on this day all the follicles are smaller than 10 millimeters, the scan is directly posted after 5 days. But if there is already a follicle which is dominant, which is larger, which is blood flows, then based on 2 millimeter a day growth rate, the next scan is posted when the follicle is expected to reach 17 or 18 millimeters. If instead it is an IUI cycle and only oral ovular gens are to be used, that is when the first scan is done on the last dose of the oral ovular gen, and after that, the same principle is followed. If all the follicles are smaller, call directly after 5 days. But if there is already a dominant follicle, find out when it is likely to reach the size of 18 to 20 and accordingly call the patient. If that is so, measuring the follicular size correctly is important, and I would want to emphasize here now that the correct follicular size or the correct mean follicular diameter is to be measured by measuring 3 longest orthogonal diameters and a mean of that. That means that you have to take 2 orthogonal planes, the longest section of the follicle, and from there 90-degree rotation of the probe leading to the transverse section of the follicle, measure the longest diameter perpendicular to the long diameter on the long section, and on the transverse section, the longest diameter parallel to x-axis is the third diameter. The mean of these 3 is the mean follicular diameter, but if the follicle is spherical, it is not oval. In that case, one may take only one diameter, and that is to be a AP diameter, preferably, and not a side-to-side diameter. As the follicle grows to ovulation, about 24 to 36 hours before the ovulation, a hypoechoic halo will appear surrounding the follicle as marked by my arrow, and it is around the same time that a tiny solid projection, which is seen here, may appear, which is probably a cumulus. I say probably a cumulus because you need to confirm in all the 3 planes that it remains as such. It remains still like a tiny solid projection, which will confirm it is a cumulus. Though 3D is a better method to locate the cumulus. Cumulus, of course, is a sure sign to tell us the follicle contains a fertilizable oocyte, but its presence is not mandatory before the trigger. It is about 6 to 10 hours before ovulation that the low-level echos start appearing inside the follicle parallel to the follicular wall. And this is because of separation of the innermost layer of the follicle to release the cumulus oophorus complex, which has been protected under this layer. It is around the same time that hypoechoic triangle, niche-like structures, niche-like irregularity appears on the follicular wall, which is called a rose bush thorn sign. Both the signs, they appear about 6 to 10 or 5 to 12 hours before the ovulation. On one hand, when we see these changes on the 2D ultrasound, it is important to mention here that the 2D ultrasound only tells us that the ovulation is impending. It doesn't tell us anything about the quality of the follicle. The quality of the follicle can only be decided by the blood flow. The blood flow which started appearing with the selection of the dominance of the follicle. And this blood flow keeps on increasing, gradually covers at least 2/3 to 3/4 of the follicular circumference. And remember, only the blood vessels which overlap on the follicular wall are perifollicular vessels. If you're seeing the vessel and you're seeing the follicular wall separately, these are not perifollicular vessels. So see that, evaluate that the perifollicular vessels are covering at least 2/3 to 3/4 of the circumference. And it is about 48 hours before ovulation that suddenly the Ri of these vessels decrease. It is very important here to make a note that the blood flow is always measured where you find the brightest colors on the color rim. And if there are multiple brightest areas, you may take 2 or 3 measurements instead of just a single measurement. And even if at one place you find that the Ri of the follicle goes below 0.5, that tells me that the final estrogen surge has started. So that occurs, the fall in the perifollicular Ri correlates with the final surge of the estrogen. It is after that the PSV of the follicle rises, and the PSV of the follicle, when it reaches about 10 centimeters per second, this is the time when the LH surge is going to start. Again, measure the flow on the perifollicular vessels at the brightest places. That means that it is at this point on the hormonal profile that you would have an RI of, it is at this point that you would have an RI of less than 0.5 and the PSV reaches 10 centimeters per second. It is important to correlate the follicular flow before giving the trigger because it optimizes the oocyte recovery rates, and therefore it gives you the best idea as to when to give the trigger. Moreover, if the blood flow is inadequate, the oocyte inside is also hypoxic. And in this cases, there's a high frequency of abnormalities of the organization of the chromosomes on the metaphase spindle and may lead to segregation disorders and catastrophic mosaics in the embryos. There are studies which have also denominated that if the PSV of the follicle is less than 10 centimeters per second, the chances of chromosomal abnormalities in the resultant embryos are pretty high. It is therefore essential to check the RI and the PSV of the follicle before taking a decision for the trigger instead of just looking at the size of the follicle. Moreover, it has also been documented that the follicles with more uniform perifollicular vascular network are more likely to produce pregnancy naturally because when the blood flow is more, that means the estrogen level per follicle is more, and that means that the follicle is a better quality. Though one may also use a 3D power Doppler to assess the follicular flow, and this is known as a volume histogram. You have to acquire the volume of the follicle as seen here with the power Doppler, and not just evaluating subjectively. You can use volume histogram to find out the VI vascularity index values, FI flow index values, and VFI vascularity flow index values, which respectively present the abundance of the flow, the average intensity of the flow, and the perfusion of the entire follicle. It has been documented that adding color Doppler to the 2D parameters before giving the trigger increases the pregnancy rate by about 25%. And when you add the 3D power Doppler parameters to these Doppler values, before taking a decision for the trigger, you may further get at least about 15 to 20% of the pregnancy rate from the failures. That means a good follicle should be at least 16 millimeters when it's a gonadotrophin cycle. When it's a oral ovulation cycle, should be at least 18 to 20 millimeters, should have a vascularity covering at least 2/3, preferably 3/4 of the follicular circumference, and these vessels should have an RI of less than 0.5 and a PSV of more than 10 centimeters per second. If you can see the cumulus, it's even better. And this is possible when there are 1, 2, or 3 follicles, but sometimes when there's a multifollicular development, especially in the IVF cycles, that's when the follicles are all compressed by each other. Because of that, they are D-shaped. They are no more round or oval, and it is in this cases that the volume of the follicle becomes more important than the mean follicular diameter. And the volume of between 3 to 7 millimeter usually correlates with the follicular diameter of 18 to 24 millimeters. But it's very important to understand, interesting to understand that all the follicles up to about 0.6 cc in volume can give you fertilizable oocytes. And there are some other studies which have also, the studies which were done earlier than this said about 1 cc, and you would definitely get a fertilizable oocyte. It is for this purpose that whenever there are multiple follicles, instead of measuring the size and the 3 diameters of individual follicle, we prefer to use what is called 3D ultrasound with a software called Sono AVC, which color codes every follicle, and therefore it doesn't overcount the follicle no matter how many follicles they are. And moreover, it also gives you the X, Y, Z diameter, mean diameter, and volume of every follicle. But to us, the important parameter is the volume release diameter, which is mentioned as dV. This is the diameter of the sphere, which has the same volume as the volume of the follicle. So that is your decision-making column, or the decision-making value for the size of the follicle. It is this Sono AVC which is also useful to decide what should be the trigger, and the decision making on the trigger this way prevents not only OHSS, can also be used to prevent the possibility of multiple pregnancies in cases of IUI cycles.